sepsis. So, who here has ever died of a paper cut? Yeah, I know, me too, totally, for sure. We've evolved our bodies in a very specific way so we don't die from paper cuts, even though we totally go to the ER for this, right? Triage level 2, something like that. But we've evolved so that we increase circulation to our site of injury. And we do this very specifically. When you do get your paper cut, one of the first things you'll notice is it starts to swell, it starts to throb, it starts to ache. Well, it's painful. That's a brilliant side effect, so you don't do it again. It gets hot to the touch. All of this is increasing circulation. And we increase our circulation because our immune system is only going to do so much good if it's just hanging out in our blood vessels circulating around. We want it to get out into the tissues, the area of injury, and get our white blood cells down there. So the first thing we do is we vasodilate. We make our pipes bigger, because the bigger your pipes are, the better your flow is. And then your immune system's not going to do you any good if it's just staying in your blood vessels, so it's going to open up your blood vessels and make them nice and leaky, so that all of your white blood cells and all of your other parts of your immune system can get out of your blood vessels into the tissue and then come on out. Good morning. Did you bring me coffee?
Yeah.
Cool. Thanks.
You give a sip.
My tea's kind of warm.
We'd appreciate it if you were on time next time.
In my mind.
And of course, you don't want to die of your paper cut. You can tell I've had a little bit to drink last night. Ignore that. I have some tea here to rehydrate. Then you're going to bleed, and you want to bleed because you have to flush out or irrigate your wound, right? Head wounds, they bleed a lot. You want them to bleed. You want to irrigate out that wound, get all the foreign bodies out that you can. But I don't want you to bleed to death from your paper cuts, then you gotta clot it off too. So we do this on purpose. We do this to clean out our cuts. We get our immune system down there. So we vasodilate, we open up our blood vessels, and then we bleed, and then we clot, okay? It's great. It works really, really well. Until it doesn't, okay? When you go from a localized area of injury to a systemic area of injury, you're doing the exact same things. You're vasodilating, but now you're doing it to all of your blood vessels. All of your blood vessels are gonna get open and leaky. And then you have damage to your vessel linings, and so your platelets start to clump up in those areas, and then you attract blood clots. And then your body says, oh no, we've got too many clotting factors invested in these blood clots. Let's start breaking them up. And then you get to break up clots and make clots at the same time. You get to bleed to death and clot at the same time. But don't worry, we'll kill our patients many different ways today, okay? But that one's called DIC. So what is sepsis? It's just, honestly, the transition between that localized injury or infection and what happens when it becomes systemic. Doesn't matter if it's a paper cut or if it's urinary tract infection or it's Taco Bell from last Sunday. You had this localized reaction and something happened and now it became fully systemic. So going back to biology, which I think was probably only a year or two for most of you guys, right? Biology class, your first line of defense is your skin, right? Right underneath your skin, you have these chemokines, and chemokines are your shouters. They're the ones who say, something's going on here. We need to mobilize the troops and get everything down here. So the first thing that kind of happens is those chemokines get stimulated and they send out the bat signal, okay? Right under there is also your mast cells. Your mast cells release histamine. Histamine is going to come down to the endothelial lining of your blood vessels and say, open up, I need to get everything out into the tissue. Okay, you think about histamine, you think about like allergic reactions and you get like hives and welts, or think about like the swelling in the face. That's just, mobilizing fluids, right? So think about opening up and mobilizing fluids when you think about histamine. Okay, and then you've got all of your immune system components. So things like your phagocytes, which will just literally eat all the bad guys. And then you have your chemotaxis cells, your B cells, your T cells, your white blood cells that are just gonna come in and basically destroy any foreign invaders that are there. Okay, now all of that is literally a battle scene. You've got friendly fire. You've got all of this stuff going on with, the white blood cells trying to kill all the foreign invaders. And you create inflammatory damage here to your blood vessels, okay? And so you're dealing with a lot of issue there where you can actually get the blood vessel lining kind of injured or stuck, and that's where the platelets start clumping up around your blood vessels. And that's where we get the endothelial damage, and we'll talk about that a little bit more. This is just a much fancier guide to say the exact same thing, but it's laid out in a nice, pretty chart form. So basically, if your physical barrier gets disrupted, you activate your immune system, and that's where you get like your interleukins and your tumor necrosing factors to get your blood cells to come out and just chemically destroy any foreign invaders. Your white blood cells come around. All of this is increasing circulation, which is where you get the swollen finger, the throbbing from the swelling, the heat. It's all just increased circulation, okay? So what we deal with in sepsis is basically like having a tire, and it has a bunch of holes in it, but I got no fix-a-flat. So what do? We just keep filling it full to try and keep the system running, okay? So really basically, if you're vasodilating and you're getting leaky, you lose your circulatory power in your system. If you're losing your circulatory power, then you can't deliver the goods. You can't get the oxygen and the sugar down to your blood cells. You can't get rid of your waste. Well, when you do that, your cells die. You get enough cells to die, you kill an organ. You get enough organs to die, and it's game over for your patient. So what do? We give 30 milliliters per kilogram of fluid, right? They pound this into all of us, right? How did we come up with 30 milliliters per kilogram? Was it some really amazing research study that they've replicated over and over and over again to say, this is great science, this is the standard of care, we're gonna do this for everybody? No. All right. It came out of 3 very large trial studies that they used to kind of disprove that the central SCVO2 catheters and CVP weren't having any big outcome. So the story of sepsis treatment basically began with Dr. Rivers, and he's the guy who kind of fathered end goal-directed therapy, right? He's the one who said, if you put in a central line, you measure SCVO2, CVP, you give them fluids, you give them antibiotics, we can save mortality rates by 30% or more. It was really good stuff, and so we had all these programs, we replicated this across the United States. We had music videos, we had clocks, everybody had these like programs to get it adopted in their hospital, and we did pretty well. And we really did improve mortality rates throughout the United States. But a lot of people were a little bit skeptical about the central line catheters, especially, and the SCVO2 as an outcome. And so they did these 3 really large trial studies. One of them was called Process, another was called Arise. And for the life of me, I can't remember the third one. I forgot yesterday too, and I didn't even bother to look it up. And I can't remember it again today. But these trial studies basically tried to suss out what part of the protocols are actually saving people's lives. And during these 3 large trials, they were able to prove that doing the SCVO2 and the CVP had no outcome to patients' mortality. So basically, if you pay good attention to your patients, you give them antibiotics and you give them fluids, you have the same outcome as if you followed the end goal-directed therapy completely. So basically, that's when the trend of SCVO2 and CVP went away. I guess this roundabout story is to come around to tell you that during those 3 large trial studies, the average amount of fluid they gave was 30 milliliters per kilogram. So when the Surviving Sepsis campaign came out and did their recommendations, they said that this is a good amount of fluid to use. Well, the Centers for Medicare and Medi-Cal use that number as their reimbursement protocol. So if you get a septic patient, this is the gold standard. You have to do this in order to get reimbursed. And policy will always follow money, okay? So we're kind of married to this number for a while. The average between clinical research and actual change in clinical practice is about 18 years. Hopefully things are kind of speeding up in the day and age of COVID. In fact, sometimes we're doing things in COVID years where somebody tries something and then within the year we're all doing it, right? But it takes a long time to go through peer review and have replication and actually get people to adopt change. I guess my cynical nature kind of comes out when we start putting everybody along the same pathway and say this is going to be the best amount of fluid for everybody, right? So they're currently doing some really good trial studies to look at how much fluids we're giving. Should we be giving blood pressure medicines before we're giving all of these fluids? Should we be using lactated ringers above normal saline? Lots of things are going on right now, but it's going to take a long time for change to happen, okay? In the meantime, this is how we get paid unless we disprove that the fluid is not a good idea for this patient. My sneaking suspicion is that people don't fit into algorithms very cleanly. I don't think everybody deserves the same amount of fluid. I think that people react very differently to fluid, right? And so it's gonna be hard to treat everybody exactly the same, even though we seem to really love algorithm care here. Yeah, that was a long talk about that. Moving on to another slide. Here's another problem. We're leaky creatures anyway. So I always thought after taking anatomy classes and things like that, that our blood vessels were like plumbing. When you had a problem, it was like a plumbing problem. You had a clot in there, you needed some Drano, or you needed to extract the clot, right? But I had this vision in my head that our blood vessels are like solid pipes, like Mario Brothers solid pipes, okay? And it's not like that at all. Our vessels are super leaky. There's traffic coming and going from different points all the time. So that if we give an average person a liter of lactated ringers, the half-life of that lactated ringers is about 30 minutes. Which means if you give a liter of lactated ringers and then you do a fluid tracer study to see where that fluid went, within 30 minutes, half of it is back out into the extravascular space. Okay, and that's a normal person, all right? So then if you take healthy volunteers and you render them hypovolemic by getting them to donate a whole bunch of blood, and you do that same fluid tracer study, you lose 70% of that in 30 minutes. Your septic patients are even worse because they have the endothelial damage from all that inflammation and the friendly fire and the toxins and those kinds of things. So they're extra leaky, and then they had that whole histamine thing happen as part of their treatment protocol, basically. So now they're extra leaky, right? So if you give a septic shock patient a liter of fluid and you do a fluid tracer study on them, they lose 95% of that fluid bolus within the hour. So when we're giving 30 milliliters per kilogram, where's that fluid going, right? The endothelium is that lining around your blood vessel, okay? It's the gatekeeper. You can have lots of messengers coming from your brain or your different systems in your body to say, this is what I want the blood vessel to do. But it's the actual endothelial lining that's going to either tighten up or loosen up, or they're going to open the junctions or tighten the junctions more. And so when that endothelial lining gets damaged, it can get stuck in a certain form. And it just doesn't react very well. It's damaged area, okay? So a lot of sepsis research these days is trying to concentrate on how do we repair the endothelial damage. Because a lot of the other treatments is all just Band-Aids until we can fix the actual problem, right? So that leaves us in the position where do we bolus or do we not bolus these patients, right? And it's really kind of a you're damned if you do, you're damned if you don't kind of scenario. We know that if we don't give them fluids, they're depleted in their intravascular space. They lose their circulatory power. And if you don't have circulatory power, you're gonna kill your patient. So we gotta give them some fluids, right? We also know that when we give fluids, it doesn't stay where we want it to stay. We could be increasing the endothelial dysfunction and the harm to the actual blood vessel because this is, more fluids to that area. And then the edema can sometimes be unreal and create a lot of problems just in itself. So we talk edema, we're not talking about the peripheral edema of our CHF friends, right? This is edema, that 30 milliliters per kilogram that went everywhere. So this is a case study of a gentleman who got shot through the heart, and during his initial resuscitation phase, he received about 12 liters of fluid, as well as his blood products, right? So they kept him alive enough to get to surgery, and they repaired the hole in his heart, and he survived it. But where did all that fluid go, right? So this is his gut, his intestines, and you get to a point where you've swollen so much you don't fit inside a fixed compartment. And if you're stuck inside a fixed compartment and you're swelling that much, you will literally just break down, so you just tighten down so much, all that pressure, you'll have no circulation. So for these people, they have to open up the abdomen and basically bring out the intestine so there's enough room for the swelling. Well, the thing is when you have this much fluid leaking out into the tissues, it's not happening in a specific space. You imagine this guy and you think about his liver, you think about his lungs, right? Pulmonary edema with all this fluid leaking out. You think about his heart, okay? When you create this kind of congestion, you literally create a barrier for cells to travel, right? For the glucose and oxygen and blood cells to get around and actually do their job. And then the organ's just not gonna work well. I can't imagine that he's absorbing water or moving food very well through that intestine, okay?
Lisa, can you just give a ton of Lasix or like diuretic?
So yeah, but then again, it's like the whole thought that when we're giving fluids, it won't necessarily stay where you want it to. Mm-hmm. When we use Lasix, we don't get to necessarily pull it from where we want it to pull either. And then, like, I'll use it to kind of go on a little side note too. Like, think about, well, why don't we just use a bigger molecule, right? Maybe it won't leak as much. So if you use something like albumin. Hey, did you bring coffee for everybody?
It's Sepsis. Good seeing you guys.
You want to stay and hang out and get sepsis bashed into your head?
I already got enough bash in my head from him.
Oh, Jimmy.
Good answer. Good answer.
We like it.
We miss
We miss you, Jimmy.
Bye, guys.
See ya.
Jimmy's up.
So maybe we should just use something with a big molecule, right? Because it won't leak as quickly. You use like an albumin or a Hespan or something like that. It's a much bigger molecule. The thing is if you remember when big molecules shift, they attract and pull other smaller molecules with them. So it does take an average of about 6 hours for an albumin molecule to move out into the extravascular space, but it can pull a lot of other fluids with it. That's one theory. Albumin is still recommended. We see good outcomes when they do studies with albumin, but things like Hespan and Hetastarch, they say actually cause more damage. And then we just don't seem to use albumin as much because it's more expensive, and saline literally costs a quarter or something like that. So is it a good idea to maybe use more albumin? There's studies out there, but will we do it? I don't know.
What about whole blood? I mean, when you take like TNCC, they always say if the patient's in shock, you give them 1 liter of crystalloid solution and then stop, because that's gonna be the worst thing you can do.
Mm-hmm.
Then you want to do whole blood products.
Yeah.
And I just wonder why that hasn't crossed over to sepsis yet.
Yeah,
the
and
whole,
then
saline thing was cheaper. But
and then whole blood, you've got oxygen carrying capacity, right? So saline is literally just salt and water. It's a volume expander. It's not actually carrying any of the goods to do things, right? So I would think that's a great concept too. In reality, you've got a patient who's in an immune compromised state because they're septic, and then you're giving them blood from someone else, even though it's the same type. It's a foreign substance, so it can create an inflammatory response dealing with someone else's blood. It's kind of like a tissue donation, an organ donation kind of thing. It's not to that extent. The other thing is when you donate blood, it goes through a whole processing thing. And so when it comes in, it can have substances or breakdowns to it that your body then has to clean up. And so if you're in a compromised immune state and then your body starts dealing with donated blood, it can increase the inflammatory process. So there is some studies out there that, especially at the beginning of River's trial studies, we did give a lot of blood products. But I think at this point, they've basically come down, like the Surviving Sepsis campaign and stuff like that, says don't transfuse blood unless you're less than like 7 or 8, kind of like we do with our other
Please.
anemic patients. Yeah. Does that kind of make sense? Yeah. Okay. So I guess I wanted to say this again, but basically we're damned if we do and we're damned if we don't, right? So we've got to give them some fluids, but if we overdo it, we're making things worse. So basic studies that are out there right now just can correlate that when we use a fluid heavy strategy, the more positive fluid balance that we have, the higher the correlation to mortality. It increases our days on a ventilator, it increases our ICU length of stay, it increases the severity of organ dysfunction. I mean, kidneys, they don't like to be under-resuscitated and they don't like to be over-resuscitated. A lot of our sepsis survivors end up on hemodialysis and things like that. So randomized control trials can tell us that fluid-heavy strategy is not such a good idea. Observational studies, again, can kind of show that there is a correlation. Correlation is not causation, but we're certainly seeing trends where if we have large positive fluid balances, we increase our mortality rates. There was an interesting trial study that came out of Africa recently. Africa, sub-Saharan Africa being a resource poor country. You think about, find a way to say this right. It would be unethical to kind of create a randomized control trial study where you have the resource to give fluids and you suddenly withhold it in the name of science, right? You have to have an ethical just basis for creating your studies. And if you have somebody who's sick and hypotensive in front of you and you're like, you're in this arm of treatment and we don't want to give you any fluids, that feels kind of a little dirty, right? If you go to a place where they just don't have the resources, like sub-Saharan Africa, you can kind of create those situations just by nature of how things are running there, okay? So they did this FEAST trial study in sub-Saharan Africa where they had PEDS patients, and they basically said, we have a limited amount of saline to give to people. We're gonna put our kids into the ones that are gonna get fluid resuscitated and the ones who are gonna use basically usual care, antibiotics, the best we can do for you kind of thing. And by doing this, they found that their group of kids that received IV fluids actually had higher mortality rates, okay? So this is a small subset of patients. This was in a resource poor area. Can we then extrapolate that data into a larger way of thinking? I don't know. But a lot of the people who are very critical of large amounts of fluid resuscitation are kind of pointing to this study and saying, hey, look, maybe we're on the wrong track entirely. That kind of thing. So think about in your head, what prompts you to give an IV bolus? Is it low blood pressure, tachycardia, stroke volume index? Because you know that directly from triage, right? No big deal. CVP, gone the way of the dinosaurs. Capillary refill, good endpoint circulatory measure, or because someone told me to, right? Yeah, so basically most all of us react to a low blood pressure. Just anecdotally from my own life, I can say absolutely all the time. This is when I start to go, oh, I need fluid and I need fluid quick, right? So this was taken from, they didn't do these studies on purpose, they did fluid studies, and then during those studies, what prompted people to give the fluids? It was almost always blood pressure, okay? CVP, you can see over time, it's just totally gone the way of the dinosaur because it was basically disproven to be very effective measure. of figuring out how well people were responding to fluids. They said it was accurate about 50% of the time, so you can flip a coin and get the same information. Heart rate tachycardia can be caused by lots of different things, maybe not necessarily a fluid depleted state. Urinary output is always a good idea, because if you're not peeing out very much, well, maybe you don't have enough in you. And capillary refill, again, is a really cheap and simple method for looking at end organ perfusion or tissue perfusion. But yeah, we all react to blood pressure, and we do that because hypotension literally just defines uncompensated shock, right? It's that simple. If you have a low blood pressure, you are in uncompensated shock. So you get those little old ladies who come in with a low blood pressure, like, oh, you live there, right? They do. Or you get somebody who comes in and they have low blood pressure and you're like, oh, but you had to walk in from the parking lot, there's a lot going on, and you suddenly had to wait in the waiting room for like an hour, and then you got back here, let's just give it a little time, have you laid down for a while, maybe you'll get better. Or maybe you had the wrong blood pressure cuff on. So I think we see these low blood pressures, but we kind of like, okay, well, let's give it a little time, or let's kind of see what's going on. But when you see that low blood pressure, if it's real, maybe we need to check to see if it's real, it's uncompensated shock. So let's remind ourselves about what's happening with shock, right? So this is the story of shock, big storyboard here. So right at the very top, the story of shock is a decreased intravascular volume. So it doesn't matter, is this distributive shock, cardiogenic shock, hypovolemic shock, septic shock. It's all about the fact that you're not getting good circulatory power going on. You have lower amount of circulating fluids, okay? So the minute you have a lower amount of circulating fluids, your cardiac output goes down. What's coming out of your heart is coming down. So your body's gonna react very quickly. And the first thing it does is it releases catecholamines. And catecholamines are gonna increase your heart rate, and it's gonna increase your contractility. Staffing knows this, right? If we don't have enough staff, just make them work faster and harder. It's gonna work for a very short period of time. But it's not gonna work indefinitely, right? Increased systemic vascular resistance. So we're gonna try and get our blood vessels to tighten up so we can return more volume. At the exact same time, if you follow the storyboard on the other side, we're gonna start to shift our interstitial fluids. So at the blood vessel level, we're gonna basically recruit as much fluid to come back into our blood vessels as we can. We're gonna release aldosterone and ADH, basically send signals down to our kidneys and be like, hey, knock it off, don't pee. We don't need to lose any more than we already have. And by the way, quit filtering the kidneys entirely. That's a really expensive fluid mechanism. Let's just bypass that entirely so we keep the volume kind of more centralized. And then your spleen, which is basically a holding vessel for a lot of blood and white blood cells, basically just get everything out here. So you have a splenic discharge and you start to incorporate that into your circulating volume too. Okay. So all of that is working very well for a short period of time. In fact, you get into this almost hyperdynamic state of shock where you actually have a lot more coming out of your heart than usual. You can even almost like be in a state of exercise kind of, okay? And all of that works very well for a short period of time. It's all just Band-Aids, and you haven't fixed the actual thing that started it, right? So if you come back down to the middle where the storyboard joins again, you had that period of hyperdynamic state where everything was compensating, doing really well, but you still haven't fixed anything, so you lose your cardiac output again. And this is the point where you finally lose your blood pressure. When you lose your blood pressure, you're not circulating to the tissues. This is where you start to kill cells. You kill enough cells, you kill organs. You kill enough organs, you die. Okay? The thing is that we're reacting to the low blood pressure just a couple steps from game over, right? So we want to start thinking about trying to react a little bit quicker or a little bit more dynamically with our sickest group of patients by starting to react to their low cardiac output state. So that means we get to talk hemodynamics, right? Because y'all got time for hemodynamics in the emergency room. Back to nursing school, and your NCLEX exam. So what was this, like 2 years ago, 3 years ago, something like that? We learned that cardiac output was what's coming out of our heart, and it's made up of our stroke volume times our heart rate, right? Because how fast you're working and how much you're working is going to determine your outcome, right? We divide stroke volume up into our 3 groups. We have preload, what's coming into the system. We have contractility, how well our system is working. And we have afterload, the amount of pressure the system has to overcome for it to circulate, okay? So now we get to talk about all these different things. Yay! More caffeine, guys, we need to be more excited. No? All right, so cardiac output is the amount of flow coming out of the aorta in a 1 minute period, okay? The average person has about 5 liters in their body, and the average cardiac output is about 5 liters a minute. So that means you're doing an entire fluid change about every minute. If you were to get into strenuous exercise, training for your next Ironman, you can go up to 7-fold that, okay? Can you imagine 35 liters coming out of your heart every minute? Pretty amazing. Not mine, I don't do that. We're going to talk about indexing, okay? Because that 5 liters is going to feel very different to Arnold Schwarzenegger than it is to Danny DeVito, okay? So any number that we're getting hemodynamically in the emergency room or anywhere, you want to index or take into account the patient's body size, okay? So I don't care about a lot of the other numbers that you're going to see show up on your NICOM, your cardiac output, your stroke volume. I care about your index numbers, so your cardiac index, your stroke volume index. And in fact, stroke volume index is going to be the big golden number that we're all going to follow, okay? So stroke volume index is the amount of blood flow coming out of the aorta with every heartbeat. So this is the most sensitive. You don't have to wait a full minute to get an average out of it. This is heartbeat by heartbeat, what's going on with the patient. And this is what we're going to be watching with our non-invasive hemodynamic monitors. Okay, so we'll figure out how I want to talk about this. So cardiac output, stroke volume index is kind of what we're tracking, what's coming out of the system. Preload is what's coming into the system, contractility is how well it's working, and afterload is the pressure you have to overcome, right? So these are the levers we're going to manipulate to get a good stroke volume index, right? So we're gonna talk about afterload, but really quickly, because I'm gonna totally forget to talk about it later. When you want to fix a stroke volume index, the first lever that you want to manipulate is the fluid, the preload, okay? You ever heard the saying, you don't wanna squeeze an empty tank? We wanna fix the fluid first. So whenever you have a shitty stroke volume index or things are kind of circling the drain, you wanna fix your fluids first, your preload first. When you can't give any more fluids or they're not accepting or they're not fluid responsive, then you move to your afterload and you say, am I squeezed tight enough or am I loose enough, right? Because at that point you need to squeeze the tank or make more room for circulating fluid, okay? So first you fix your fluids, then you fix your blood pressure. And then if you fix both of those things and you don't have a good outcome, that's where you start to work on contractility. So that's where maybe you'll add in dobutamine or something like that, okay? So now we're gonna detour into talking about afterload. Afterload is basically, are you vasoconstricted, vasodilated, or in a happy medium place, right? Do we measure this in the emergency room? Sure. You can do it in a fancy way and get something called your systemic vascular resistance index. Remember, we're indexing our number, or your total peripheral resistance index number. And this is a fancy calculation between your mean arterial pressure and your cardiac index, or stroke volume index, okay? So you can do this if you have things like your cheetah NICOM hooked up. But we're gonna get even simpler than that, and let's just talk about basic blood pressure, because you can get your afterload basically from this, okay? So just to remind ourselves, that top number, that systolic number, is the pressure in your system when your heart is squeezing. So we can get a little bit of information about the squeeze of the heart when we see our systolic blood pressure number, okay? Our diastolic blood pressure is the pressure in our system when our heart is relaxed. So this can directly infer what our vascular tone is like, okay? Does that make sense? And then our mean arterial pressure is the average pressure in the system. So it's that fancy calculation where you're in, I can't even remember, is it the squeezing part of the phase for 2/3 of the time and the filling for 1/3, or I have that backwards, and then you get the average of that. So it's the average pressure in the system through the whole cardiac cycle, okay? So somebody somewhere said 120/80 is the perfect blood pressure, something like that. I don't know if I believe it. You get people who come into triage and they're like, well, is it a good blood pressure? I'm like, well, if you're not rupturing an aneurysm and you're not passing out, it's a great blood pressure, right? But somebody somewhere decided 120/80 is a good blood pressure, okay? So let's look at some different examples. The first one over here is 89/60 with a map of 70. So under 90, oh my gosh. So these are the ones where we're like, okay, systolic under 90, now we gotta do something. But what do you think about the diastolic blood pressure of 60? It's okay, right? It's fairly decent. You've got okay tone in your vessels. And in fact, my mean arterial pressure is 70. And if you remember from the last time you had to titrate Levophed, we try and keep that mean arterial pressure above about 60, 65 to demonstrate that you've got good circulating power. So this blood pressure of 89/60, certainly there's something going on, right? We don't like to stay with a blood pressure like this. The systolic blood pressure is the one that's kind of low. So there's something going on with the squeeze of the heart, which could be my preload, it could be my contractility. There's something going on there, but I've got decent tone in my blood vessels, okay? Next example, 144/41 with a map of 75. Well, that's almost hypertensive, right? If you go to the clinic, we'll book you for a recheck in like a week or two, right? But what do you think about that diastolic blood pressure? 41. It's a little bit wimpy, right? A little bit wimpy. Our mean arterial pressure is 75, so we've got good circulating pressure, but it's only because our systolic is high enough, right? So if that systolic starts to drop, and even if it's dropping into the like 110, 100 range, I might not have a good map at that point. So this is actually somebody that I'm watching kind of closely, even though their blood pressure is adequate right now. Okay. Last example over there, 100/38. Oh yay, their blood pressure is over 90. I'm kind of excited to chart that, right? Because I get to put one in over 90, especially if I've been trending a couple of them under 90. I'm like, hey, I'm over 90. But what do you think about that diastolic blood pressure, right? So super wimpy. And our mean arterial pressure is 58. So we're not demonstrating good circulatory pressure. And if we were on Levophed, we would need to titrate this up at this point, right? So this is actually the sickest patient on the board, even though their systolic's less than or greater than 90. So just a good reminder of some good basic blood pressure and how much information you can derive from a blood pressure, right? Well, by the way, does IV fluid improve blood pressure anyway? Okay, so this is just food for thought. But if you do a randomized control trial where you give IV fluid at room temperature or cool, or you give warmed fluid, which group do you think has the higher blood pressure? It's the group that got cold fluids or room temperature fluids, right? We know that when we're cold, we vasoconstrict, and when we're warm, we vasodilate. So if you give a patient warmed fluids, you get no rise at all in mean arterial pressure. So my whole life I've given IV fluids, and I subsequently see this rise in blood pressure, and it reinforces this thought for me that when I give IV fluids, I'm improving blood pressure, right? It may be that these patients are reacting more to the temperature than they ever are to the actual IV fluid, okay? So think about that a little bit too. While we're talking about temperature, let's talk about warming fluids too, okay? Because when we start to give patients 2, 3, 4 liters of fluid, dang, that can really drop a person's blood pressure, right? ORs, anesthesiologists, they spend a lot of time studying temperature management because when you sedate and paralyze a patient for surgery, they don't have the same hemostasis mechanisms to warm their body up. So if you were to give a patient like that a liter of fluid, they lose their core body temperature really pretty quickly. In fact, for every liter of saline, you can decrease the temperature by up to 1 degree, right? So when we're giving a couple liters quickly on pressure bags, and these people who are already sick have to then create the energy to warm their bodies up, we're taking a whole lot of energy from them, right? We got into this whole sidetrack last time where we talked about just individually the last time we personally received IV fluids. How many people here have gotten IV fluids before? Right? How cold were you afterwards? Seriously, like chattery cold, right? So all of our patients who've been sitting in a waiting room and not moving around and they're already cold, and then we throw them into the room, we put an IV in them and we give them fluids, these people get really, really cold. So if you get anything else out of this, go ahead and give your patients warm blankets. And if you have a sick patient and you're giving them lots of fluids, go get the fluid warmer for them, okay? Even though you don't get that satisfying, nice rise in your blood pressure because you've made them cold, it's really a lot kinder to give them some warm fluids. Plus, you're not taking such an energy sink from that patient to try and have them warm up their bodies from the fluid. I guess that's all I was going to talk about. Okay, moving on. Okay, so stroke volume index is our golden number that we want to fix. And the first thing that we're going to try and manipulate is that preload level. So then what is preload? The fancy definition of preload is the amount of ventricular stretch at the end of diastole. What the heck does that mean, right? Okay, so diastole is when our heart is at rest. When our heart is at rest, that's when we're filling the right side of our heart. Okay, so this is the time of filling. The heart is like a rubber balloon in the sense that the more that you fill it, the more it's going to stretch out, right? So preload is fluid dependent in the sense that the more you put into that container, the more the stretch is, okay? So just think fluids when you think preload. What's going into the system? Then we get to talk about this guy named Frank Starling. And you probably had to take a test with a question about this on it at some point in your life. So you maybe heard about it a little bit. And this is the guy who said that the heart is a lot like a rubber band, okay? And so when you stretch a rubber band, you get pretty good elastic recoil and stuff coming out, okay? If you stretch that rubber band even further, you get even more elastic recoil and fluid to come out. You stretch it even further. Have you ever snapped a rubber band on yourself? Stretch it even further, man, that sucker comes back real hard, and then the fluid will come out even faster and harder. You can get to a point where you overstretch the rubber band, and then you lose the elasticity in it, and it gets a wimpy response, and you're not getting good outflow. You can also have an old, tired rubber band that's just been working too hard its whole life, that's wimpy, and you're just not gonna get good stretch out of it, and you're not gonna get good recoil and good fluids coming out. So this is where we look for fluid responsiveness. And in fact, when we look at preload, we create this kind of a bell curve with what we do. So this is the Frank Starling curve that you see on your Cheetah NICOM devices. And I'm gonna try and make this make sense, okay? You'll feel super smart after this, maybe. Okay, so preload is the amount of fluid going into the heart. So this line across the bottom is the amount of fluid we're putting in. Stroke volume is the amount coming out of the heart, okay? So if you follow this bell curve, if you start down here, we've got a little bit of a stretch in our heart, and it's coming out, and we're getting some pretty good outflow, right? The more fluid that we're giving, the more we're stretching that rubber band, the more we've got good elastic recoil and push coming out. So the more fluid we're getting, the more we're getting out, okay? And this works really, really well. So we're giving more fluid, we're getting even more out to come out, until we get to the point where we've overstretched our rubber band, okay? And that's where we get to the flat part of the curve. We've now gotten to a point of overstretch, or our patient just doesn't have a good stretchy rubber band and they're not getting a good response and a good outflow, okay? If this was just a linear curve, straight line up to the ceiling, you could indefinitely stretch that out and always get more out, but that's not how the heart works, okay? So that's how we end up with this curve. So anybody who's on the dynamic portion of this curve, the more fluid you're gonna get in, the more you're stretching, the more you're gonna get out. Anybody who's at the top of this curve, they're at the point of having that overstretched rubber band, so they're not getting very much out. Okay. All right, so stroke volume index is the number that we want to achieve, okay? This is the golden number. It's a vital sign, maybe even more important than our heart rate and our blood pressure. It's literally painting the picture of what's coming out of our heart for us, okay? It's determined by these three things. So if we push different levers over here in preload, contractility, afterload, we can get a good number for our stroke volume index, okay? We want to try and react to our stroke volume index more than we react to the blood pressure, because blood pressure is only a couple steps from game over. Does that make sense? So you'll have a NICOM station in a little bit where we talk about how we're doing this whole fluid challenge. So I'm gonna kind of gloss over this a little bit. But the concept of the fluid challenge is basically we're either gonna give a 250 bolus, or we're going to mobilize the approximately 250 cc's of fluid we all keep behind our legs. And we're gonna see, if I increase the amount of fluids I'm giving, am I getting more out? So it's just a test of change. If I give fluids, am I increasing what's coming out? Because if I give fluids and I'm not getting an increase in what's coming out, then I know those fluids just aren't doing you any good. It's either backing up into your lungs or it's going out into your tissues, but it's not entering your circulation, okay? When we do it, we're looking for a 10% change, okay? So, when I first started this, we were only gonna talk for like 30 minutes and then we were gonna do the NICOM station, but then Paige gave me a full hour. So now I get to fill up a whole hour of your time. And then I was like, well, what do I do with the rest of it? So give me just a second, because I'm not brilliant enough to figure out how to move lectures. So I'm gonna like just really smoothly here move into a different lecture somehow, while you all entertain yourselves or something.
Like a double screen. Yes.
Skills day. There it is.
I found a water station around the corner, like a water fountain. Oh, there is? Yeah. Oh, cool. Let me move this. Oh. I was like, I'm not doing my hair. I'm not putting on scrubs.
Okay, glitch in the matrix. We're back on. Okay. So just to erase the last 20 seconds from your life and pretend that we went from this beautiful lecture right into this case study. All right, so this case study happened here at Kaiser Roseville. It was a case study that I had. I believe I was working with Dr. Knott, who was not called Dr. Knott at that time, which was a really funny who's on first kind of a story, because when she first switched to Dr. Knott, somebody was like, wait, it's not the doctor before, it's Dr. Knott. And I was like, what are you talking about? Dr. Knott. And I'm like, yeah, but which doctor? Anyway, so she's wonderful. Anyway, so here we go. 10:30 in the morning, 64-year-old from home comes in to the front triage, newly widowed, so living by himself, and his chief complaint is vomiting and weakness. Initial vital signs: heart rate's 117, respiratory rate is 20, or at least that's what they wrote down, right? It's always 16 or 18 or 20. It's always an even number. If you want to fake a number, go odd. It feels more real, okay?
Yeah, 16.
Blood pressure 104/48, temperature 100.2, sat 97%. Does this patient make SIRS criteria?
Yeah.
No, no. I know, he should, right? You look at that and you go, okay, you've got a bit of a fever going on, you're tachycardic, you're probably septic or something. But if you look, the only criteria he makes in that is the tachycardia. Because we consider respiratory rate less than 20 to be normal, and the temperature mark for our sepsis patients is 100.4. So he actually comes in as a level 3, and he goes out to surge, you know, because that's where we put all of our patients. And I guess I wouldn't be talking about him if he wasn't exceptionally sick, so there you go, we can get full to triage, right? So out at surge, he gets his IV in and he gets his labs. And you know the nurse is kind of looking out because in the comment section they wrote, hey, next available bed please. So they're seeing something here where this guy is sick. And as happens from time to time, or all the time, you end up getting most of your studies done in surge while you're waiting for a bed, right? So x-ray is ready for the patient. So they now have their labs sent off, and they're now going to x-ray it back before we even get another set of repeat vitals from triage, right? So his x-ray comes back, and apologies, this isn't actually his x-ray because I'm stealing from the internet. But he's got himself a little bit of a right lower lobe pneumonia, right? Do you want me to talk about x-ray readings for chest, or should I just kind of move on? You want to go on a little tangent?
Sure.
Raise your hand if you want a tangent. Okay, all right. So, so you have your blood vessels, right? And blood vessels can either create pressure because it means for things to move in and out of the system, or you can create pressure from being congested, in which case you just start pushing things out because of pressure, right? So if you have a patient who has an enlarged heart, or you give them a lot of fluid, you're backing up their system, right? You've just got lots of fluid in that area. When you do that, the fluid backs up from the heart and it goes into the lungs, but it's in the vessel system. It's in your blood vessels. It's either fluid overload or you're giving IV fluids, but it's congested. It's not getting through the heart system very well. So you'll build up pressure in your blood vessels, and that fluid will start to leak out of the blood vessels. So when you sit this patient up for a chest x-ray and the fluid has been pushed out of the blood vessels, it's sitting in that interstitial space. You sit them up for a chest x-ray, gravity. So the fluid will fall to the bottom of the chest, okay? So if you have a fluid overload patient, the first clue is that they have a nice big heart on the chest x-ray. But the next clue is that you see a bunch of these vascular markings where you can almost like trace the tree of blood vessels. And then the fluid will build towards the bottom so that you can't see a clean diaphragm. So that's a fluid overload patient or a CHF-er. For whatever reason, they've got a lot of fluid on board, okay? Pneumonia can build up in specific areas, but it'll be more of a glob. And you can build it in the bottom or tops, but you'll see an actual condensation of inflammation or fluid consolidation, okay? Let's say you have a patient with ARDS, or what's the other term for it? Basic respiratory fluid, because you have fluid in the actual alveoli. Well, that happens when you have damage to the alveoli. So the alveoli is a really tight junction, because the only thing you want to exchange between an alveoli and a blood cell is gases, or carbon dioxide for our oxygen, right? And if that alveoli gets damaged in any way, think about our sepsis patients where it's all about opening up tight junctions, right? So the alveoli can open up and suddenly you're not just exchanging gases in your alveoli, but now you're exchanging fluids and blood, okay? So that's where you have damage to your alveoli and fluid is getting into there. So when you sit that patient up for a chest x-ray, the fluid's not going to be falling because it's stuck in the alveoli, right? So that's going to have a different x-ray picture where it's just kind of patchy and cloudy all through the x-ray, okay? Thank you for the tangent. I feel smart. Okay, so x-ray. Dude's got a right lower lobe pneumonia, okay? All right, so he finally makes it to a room. And my across-the-room assessment is he's tired. He's got kind of a sallow, pale skin to him. He tends to grunt his answers to you, and I can't tell if that's because he's tired or if he's just an antisocial man who just lost his wife. He's the kind of guy who tucks himself out of the wheelchair and gets into the gurney by like basically lugging his meat, right? So he's tired. Like he did it himself, but he's a tired dude. We put him on the monitor and his respiratory rate's 32, right? So I don't know if the triage number was wrong, which we do, or if he's just kind of worn himself out by waiting. His heart rate's still a bit tachycardic. His blood pressure's okay. His SAT's okay. All right. He now promptly vomits at coffee ground emesis, right? And I get out the hemocult card and it's positive for blood. So this guy that I'm thinking is just a bit of a pneumonia, he's got something else going on. He's got a bleed going on. So I haven't even opened up the order sets, but he's got the IV in from Surge. He gets his first bag of fluid. So this is people keeping track for the home game. Here's bag number 1, okay? All right, so on further assessment, like more than across the room assessment, he's withdrawn. He's the kind of guy who's not volunteering any information. He's just directly answering the questions. He looks tired. When you ask him how long this has been going on for, he says, nice and vaguely, for a while. But he is alert and oriented. He's appropriate. The weakness is symmetrical, so I'm not going neuro with him at all, okay? He's tachypnic and a bit shallow, but there's no acute respiratory distress. He can speak in full sentences. Lungs are clear, so there's not a whole bunch of junk going on there. But he denies to me any history of cough, congestion, or fever or chills. So he's not complaining about the things that kind of match the chest x-ray, where I thought, oh, he's a pneumonia. But he is complaining of nausea, vomiting, and diarrhea for a while, okay? So that's his basic concern. He's tachycardic. Again, kind of a little bit of modeling maybe even going on. And now we open up the chart and we get to the orders. So the initial order set is for 2 liters. So bag number 2 goes up, okay? So home game, how much fluids we're giving. All right, so we get our first set of bloods back, CBC. What do you think about the CBC? What kinds of things are standing out to you? White count, right? That's kind of the way that we're trained. Your eye just kind of goes right there to the white count. So you've got an elevated white count, which means inflammation or infection, right? And so then let's just dip down and look at our differential. So differential is measuring the different parts of your immune system components, and it always equals 100%, right? So we're just looking at the percentage of what kind of immune response you have. So anytime you have a rise in one area, you're gonna have a necessary decrease in something else, okay? It's not perfect, but in general, when you get a rise in neutrophils, that tends to be a bacterial infection. When you get a rise in lymphocytes, that tends to be a viral infection. When you get a rise in monocytes, basophils, eosinophils, those are generally allergic type of reactions. And then bands, I always watch out for bands. Do you guys remember what bands are? Yeah. They're your immature immune system. So basically, if your body is willing to send out the soldiers from boot camp before they ever finish, something bad's going on. So anytime you see bands, kind of keep an eye out on how sick that patient may get, okay? So this guy's bleeding. He's vomited up coffee ground emesis. So I get super excited because his hemoglobin's got plenty of room, right? And in fact, I remember going up to Dr. Knott and saying, hey, at least I don't gotta worry about bleeding, right? And she's like, no, Lisa, he's that dehydrated, right? Because I totally had forgotten. I'm gonna try not to trip to death here. Workplace injury, it's okay. I don't wanna work for the next few months. All right, I forgot this principle, okay? So when you're looking at your hemoglobin and hematocrit next time, try and think about this concept. So when we look at your blood count, we're looking at your blood and your plasma, okay? So the normal ratio is to have a hemoglobin to hematocrit ratio of 1 to 3. That means that you've got a pretty good balance of blood and plasma. If you end up in a situation of fluid overload or more plasma per blood, you're gonna have a decreased ratio. So in this example, a hemoglobin of 12, a hematocrit of 27%. This person has a lot more plasma on board. If you ever think about the doctors who are concerned about washing out or giving too much fluid and suddenly you get a decreased blood count, right? So you can kind of watch that. Hemoconcentrated patients are patients who have a greater ratio of hemoglobin to hematocrit. So look at this guy. He had a hemoglobin of 16.6. Maths is not my strong suit, but 3 times about 15 is like 45. So we're looking at like 48 or something like that would be the right ratio. Well, he is super hemoconcentrated, right? So this guy is like maximally dehydrated. So what's his blood count? We don't know. We don't actually know. And I asked Dr. Knott, I said, well, do I need to worry about him being anemic? And she says, we won't know until we get him hydrated, okay? So now I've got it in the back of my head, okay, sure, so the fluids are a good idea. Now we got a lactic acid back of 4.6, right? I go, okay, now we're gonna do the sepsis thing. No problems. I like the sepsis thing. I teach the sepsis thing, okay? So I feel kind of comfortable. Don't forget, these patients are super leaky. So I'm thinking I gotta give this guy a lot of fluids because I know he's super dehydrated, but he's also gonna get super leaky, okay? Next set of labs come back, Chem 7. What stands out to you on the Chem 7? Creatinine, yeah, not working that great. Glucose. Wait, what? Glucose? He's diabetic? He never said anything about being diabetic, right? Okay, lovely. He's diabetic, he's bleeding, and he's septic, okay? So now he gets to do a VBG. And look at the anion gap, right? So we gotta close that gap down. He's acidotic. This may have contributed to the lactic acid too, right? Because our DKAs are gonna have a higher lactic acid too. All right, he's not even super compensated. He's compensating a little bit, but this guy is sick, right? What came first? I don't know. You get your diabetics who, they have a high blood sugar because he wasn't taking care of himself. His wife is gone. He's maybe not eating or drinking the best anymore or taking care of himself. And so that can make him more susceptible to an infection, okay? Or maybe he got an infection and then that ruins his blood sugar because his body thinks he needs more sugar to fight off infection. So either way, we're dealing with a nice complicated pneumonia and sepsis, an acute upper GI bleed, and DKA, okay? This is the way they go. They never fit into boxes well, do they? All right, so we gave 2 liters of normal saline, and now we get some new orders. So we're gonna give IV Rocephin for the pneumonia and to fit our sepsis protocols. We're gonna give him some IV Tylenol. We gotta give him some Protonics to deal with the GI bleed. Insulin protocol, right? And then the top-off fluid order. Have you guys seen the top-off fluid order? Right? So again, we're getting reimbursed based on that 30 milliliters per kilogram. And it does say that that's the right amount of fluid to give people, or you've got to have an excuse why you didn't give that amount of fluid, okay? So these top-off orders, basically you need to find out how much he got in the last 2 hours, and then you have to get to that 30 milliliters per kilogram. It's a good way for us to keep track too, because if you have nurses that change every couple hours, or what they got in the field, what they didn't get in the field, it can get super confusing to try and trace how much fluid somebody's got. I know I don't fill out my INOs the way that I should, right? It's kind of the last priority on my charting. But this is really important, especially with these sick patients. And because I keep hamming on about fluids, let's try and keep track of them too, right? Okay. I think at this point, we get into the audience participation point. So at 12:15, we gave the IV Tylenol, we started the antibiotics. For the home game, 3rd liter's going up, because that's that top-off order, okay? Of course, we got to start another IV, because now we got antibiotics going, we got Protonics going, we got insulin going. the urine is back and it's negative, so thank God something's going right. And we take the patient to CT scan. So we did have a moment of low blood pressure at 12:15, okay? But we're kind of toddling along here and we've been pretty busy. 2:30, it's now 2:30. What are you gonna do at 2:30? So have a look at your vital signs and then decide for yourself. Do you wanna hang another IV bolus? Do you wanna start Levophed? Do you wanna start dobutamine? Do you wanna go to lunch? I do. Or do you need some more information? So kind of think and vote in your head. What do you wanna do?
I want more
Guys, you're
information.
so smart, right? Not that I really did this in real life in this order, but I kind of changed it a little bit for this lecture because I'm going to try and tell you how to do it the right way. But we need more information, right? And so the more information is going to come from putting up the cheetah Nikon. So we get the Nikon going. Our cardiac index is 2.7, stroke volume index about 28, and we do the fluid challenge, 10.9%. Is this patient fluid responsive? Sure, okay. So now what do you want to do? 1, 2,
More
3,
fluid.
4, 5. So now you have the information. Now we're going to do that IV bolus. So for y'all playing the home game, now we're on bag number 4. Okay. All right. It's now 3:45. We can kind of trace along here. Okay. Our blood pressure sucks again. Okay. Our cardiac index is 2.3, our stroke volume index 33, and our percent change now with our fluid challenge is 6.8%. So, do we want to hang another IV bolus?
No.
Do we want to start Levophed?
Yes.
Start dobutamine, go to lunch, or you need more information? I still want to go to lunch. Okay.
I'll
So,
go home. Yeah. Yeah.
this is the point where we decide we need to get some Levophed on this guy. We already thought we were going that direction. He's certainly sick enough, okay? Now we've given him 4 liters of fluid already. So when we lay him flat to put in his central line, he develops bilateral wonki, and now I'm up to an 8-liter simple mass because he's in some respiratory distress, right? He was already tachypnic when he started. He's got an underlying pneumonia. Now I've given him 4 liters of fluid in like a 3-hour period or so. So now he needs a little bit of oxygen support. The doctor says, okay, let's give him some more fluid. Really? Okay, some more fluid. We're gonna go kind of slowly. So we're on to bag number 5, okay? And here's our chest x-ray now, okay? So we had gone on that little tangent, that little side street road, and we looked at chest x-rays before. So we had that little bit of a right lower lobe pneumonia. Where's the fluid? Is the fluid in his interstitial space so that when we sit him up for a chest x-ray, the fluids fall into the bottom of the lungs? Or is his fluid in his alveoli? In his alveoli, right? So this is now a case of ARDS. ARDS sucks, okay? Because once you get fluid into the alveoli, it is so hard to get it to come back out. And you damage the alveoli in the meantime. So these are the patients that end up on ventilators for quite a bit of time. Okay, this is really hard to fix. Okay, but the good news is we started the norepi drip, right? So we got that central line in, we got the Levophed going. We're titrating kind of quick. He's not super responsive to the Levophed. And that happens sometimes, right? So now it's 5 o'clock. Have a look at your vital signs at 5 o'clock. Our Levophed is now maxed out at 0.5, okay? So think about what you want to do. You want to hang another IV bolus? Start another vasopressor? Start the dobutamine? Demand an ICU bed now. Just give it to me, right? Or do you need some more information? I still haven't had my lunch break, right? Cranky. So what do you guys want to do? Another vasopressin. You guys are smart, man. Okay, so that's what we do. We add on vasopressin. It works by different routes, okay? By the way, I forgot to say this, but can you give Levophed in a peripheral IV? I know we kind of waited in this case to put in the central line
For a limited time.
for a limited time, but absolutely you can, okay? So the problem with Levophed in a peripheral IV is Levophed is a potent alpha constrictor. Alpha constrictors, all they do is they go to the vessel and they go squeeze, very basic stuff, okay? So if you were to infiltrate or extravise that alpha into an area of tissue, it's so strong in that area and you're giving such a high concentration that you're going to go to those little localized vessels and it's going to clamp down so hard it's going to kill the tissue, okay? So in that case, the cure for it or the treatment for it would be to give an alpha blocker. And in this case, it's called Regitine. You can get it from the Pixison override. Regitine would then need to be given anywhere you think you may have extravised the Levophed or any other alpha stimulator, okay? Because then you can open those vessels up and save the tissue, okay? So yes, you can give Levophed into a peripheral IV. Keep an eye on the site. Hopefully you have an IV that you trust and you can kind of keep an eye on it, okay? And we don't want to wait. I mean, sometimes we have to wait for that central line for a really long time. So if you can, go ahead and start the Levophed in a peripheral IV.
How do you give the Regitine? If you have
Like the rabies,
oh, just IM or
So you give it subcutaneous.
around the site.
I've personally done it 3 times in my life. All of it at county, all of it very early in my career, because I don't think we put in a lot of central lines super quickly, so we tended to give more Levophed peripherally. And what we would do is we would give that Regitine like a milliliter or so to the infiltrated IV so it would follow the path. And then you put it on a 25 gauge subcutaneous needle. And it's kind of like when they give
The rabies.
like a rabies treatment where they just, I mean, you go everywhere around where you think you may have infiltrated, you just give a little bit all around there.
Okay.
It's painful. Hopefully your patient's kind of unconscious or give them something for it. Okay. All right, so let's see how our patient's doing. Oh, I cheated. Hang on, go back. Okay,
Yeah, the cardiac index.
545. Everybody look at 545. So we're a little bit tachycardic. Our blood pressure's doing okay. He's still kind of working a bit to breathe, but we've got him at 95% SATs. Cardiac index 2.5. Is he fluid responsive? No. Vasopressin's up. Levophed still maxed out. So that stroke volume index, which just 45 minutes ago had been at 31, is now down to about 22, right? So the amount coming out of my heart is not great. I've kind of maximized my fluids as best I can. I've got him to a place where I feel like his afterload is okay, but my stroke volume index is still kind of puny. So what's something we can do at this point? Do you want to hang another IV bolus? Ask for a Lasix strip, like, so fluid overload Lasix, I think you'd asked about that. Totally, I'm with you. And they will. So a lot of these patients who undergo initial fluid resuscitation, it is standard protocol once they get to ICU. After that first 24 hours, they start fluid unloading these patients, okay? So they don't just leave it on there. They do start Lasix either by pushes or by drips, very common, okay? There's protocols around that. We just don't see it because it happens the next day and the day after. At this point, you want to start dobutamine, demand the ICU bed, or do you need more information?
I say demand the ICU bed.
I'm totally on board with you. I don't even know where we
I
took
mean, he's
lunch
been there all
this
day.
year,
Yeah,
right?
it's craziness.
Yeah, totally.
That's
So this is the point where we're gonna start the dobutamine, okay? Because we've maximized the preload as best we can. The patient's no longer fluid responsive. It's not gonna do me any good to work that lever anymore. We've got our afterload, right? We've finally got some good venous tone. We did it with 2 pressors, but I'm still not getting a great output from my heart. So this is where we're gonna add dobutamine. Dobutamine is a direct contractility drug. So it's gonna make that heart work just a little bit harder, okay? All right, so you made it. That was it. I think I even talked more this time than I did last time. But anyway, this was in Delta Pod. What was it, last year? I love this. This is like the epitome of the ER world right now, right?
Yeah, just someone used it.
Yeah.
Anyways.
Someone did it.
Someone did it anyways.
Right, I love it.
Yeah, for sure. Any questions?
That was fun.